Hello and good afternoon to everyone watching us live. On this very special occasion of World Health Day, on behalf of Docplexus, we would like to thank all the doctors and healthcare professionals for striving to enable a healthier and happier world. This year's theme for World Health Day 2021 is Building a Fairer and Healthier World. With this note, let me introduce our speaker for today, who's a Padma Shri awardee and a well-known ophthalmologist who has dedicated his life for bringing back the light in the eyes. We have Dr. S. Natarajan with us today, who shall be talking on 3D Fantasy Vitrectomy, management of the diabetic eye. He's a nationally recognized surgeon and has received numerous awards for his contribution to the medical world. He's currently the president of Asia Pacific Ophthalmic Trauma Society, Organized Medicine Academic Guide as well. He's also the chairman and managing director of Aditya Jyot Eye Hospital and also runs an NGO for providing a better world to the visually impaired. We are overjoyed to have you, sir, and we would love to hear you.
Thank you. Thank you very much, Docplexus and Rashika for the introduction. So my talk is 3D fantasy surgery, vitrectomy for proliferative diabetic retinopathy. So the burden of diabetes, and according to the International Diabetes Federation, India has 77.7 million diabetics, and we are on the World Health Day, and then the WHO recommended that we should have a healthy life. And here, by 2025, it is estimated to go up to 134.3 million. And in fact, by 2030, according to estimates, 8.4% of India's adult population will have diabetes. And this shows the world like 77.7 in India. And the challenge is it's an epidemic, which is actually happening. And unfortunately, every diabetic will be affected in some form of the microangiopathy. And it's an incurable disease. So in case you have diabetes, you can control. It's like an animal, but you cannot cure it. That means you cannot say, from today, I don't have diabetes. So somebody has diabetes, you can control. And you have to keep it under control. And that's why it's an incurable disease. And the eye symptoms are too late. And according to me and to the experts, the prevention is better than cure. So if you don't treat a diabetic, to a diabetic eye problem, you can land up in a condition like this called the diabetic traction retinal detachment. On the to your right, you see a severe proliferative retinopathy, which is contracting and pulling the retina with some hemorrhages. And on the left, you see a proliferative membrane, the angry-looking new blood vessel. So the other condition which can produce a vision-threatening problem is clinically significant macular edema, retinal edema within 500 micron of center of fovea, hard X-rays within 500 micron of center of fovea with adjacent edema, which may be outside 500 micron limit. Retinal edema, one disc area or larger, any part of which is within one disc diameter or 1500 micron of center of fovea. And why I'm talking about traction detachment and cystoid chronic clinically significant macular edema is both these problems can produce blindness. The macular edema and the traction can be prevented if the patient with a normal eye, that means any diabetic who's from the age of 30 or 35, if he knows his parents had diabetes and he keeps checking, you know that the diabetes was not there the previous year, and the next year the diabetes is there. It takes 5 years for the diabetics to settle. If both the stages, if you don't take, then the patient develops non-clearing vitreous hemorrhage. The one shows the fundus photo where optic disc is seen hazily, and then the ultrasound shows the vitreous hemorrhage, which is mobile. And here you have a combined traction and rhegmatogenous retinal detachment, where you see a retinal hole, and then because of the traction and the pull, retina is being pulled, and you have a traction retinal detachment. And you also have if you see in the OCT, you have a fine membrane, which is because of the taut posterior hyaloid. And even these can produce reduction in vision or a defective vision. That's the reason if you diagnose diabetes and then examine the retina periodically, you can prevent them. But nevertheless, if they use Amsler chart, still you can come at the early stage, but many times the patient comes late. As you see, a membrane is formed. Because one eye may be normal and the other eye can have taut posterior hyaloid. And still you don't treat, you can develop rubeosis iridis and then also the associated vitreous hemorrhage. Once upon a time, rubeosis iridis were a contraindication for any treatment, and now we can give antivascular endothelial growth factor into the antechamber followed by 48 hours later, once the new blood vessel regresses, you can do a vitrectomy and also inject steroid. And thus, the diabetic blindness, the causes are diabetic macular edema, traction or a combined retinal detachment, and a neovascular glaucoma. You can see the rubeous iris and the iris angiography. And a treatment is to prevent blindness is pan-retinal photocoagulation, multiple monthly intravitreal anti-VEGF injection, intravitreal steroid injection, steroid implant, and finally vitreous surgery. And laser photocoagulation, we do a pan-retinal photocoagulation except the optic disc and macula, where you can maintain 6/6 or 20/20 vision. And anti-VEGF is used, or a steroid implant is used to treat diabetic macular edema. So the idea of vitreous surgery is to restore or maintain vision. The surgical objectives include thorough removal of the vitreous bleed, the endophotocoagulation to stop the peripheral anoxia, and also reattachment of the macula if there's a detachment. I want to give a case example. A 48-year-old male with a sudden diminution of vision, both eyes, since 2 days. He's a diabetic since 11 years on insulin, on poor glycemic control. And when I asked this patient, when did you check your retina first? We are doing a study. 60% of them do not know that diabetes can cause eye problem. And this man checked his eye a month before. He was known that he's a diabetic. You can see in 1 month, you cannot get this complication. That means he has had about 5 to 10 years diabetes, and he's not used medicine, and then he's come to this level. On examination, he had a vitreous hemorrhage with diabetic traction retinal detachment, both the eyes, and right eye followed by left eye. Vitrectomy was done 1 week apart. So here I'm showing you the surgery, which is a 23 gauge surgery where we use the 3D surgery. Unfortunately, we are not able to transmit or record a 3D surgery. So you're seeing it in the your computer or your mobile that we are using this 3-port pars plana vitrectomy. But 3D surgeries where you can see the 3D effect by wearing a 3D glass. So we need a separate projection for that. Here, we're not able to show that, but I'll show you the 3D system and the operation theater, how it looks during the course of the surgery. Here you see clearing the vitreous hemorrhage, and also clearing the tangential traction, which is producing, and where you're now cutting the fibrous tissue. And now I'm doing a diathermy to the fibrous tissue to prevent bleeding. And in spite of that, you can see when I cut, there's a mild ooze. So the idea is to prevent hemorrhage, so that even if you diatherm as well, you can prevent a recurrent hemorrhage, because before the antivascular endothelial growth factor, the recurrent vitreous hemorrhage was a bugbear. So we do an excellent vitrectomy, do a laser photocoagulation, and still the patient can bleed. And here you make sure you diatherm as well, and also do a pan-retinal endolaser photocoagulation. That means you ablate the peripheral retina, and then also give antivascular endothelial growth factor injection so that new blood vessel does not form, and thereby you can prevent recurrent vitreous hemorrhage. A decade back, when patients, we did not have the antivascular endothelial growth factor, we had to do this procedure called OPD fluid air exchange for a recurrent vitreous hemorrhage. That means when you do some 10 vitrectomies, 4 or 5 will have recurrent hemorrhage, 2, 3 will clear, 2 may need this procedure. So I think the advances, one is a microvitreous surgery, so transconjunctival translateral approach, as you see here, excellent fan-retinal photocoagulation, and then antivascular endothelial growth factor, diathermy, and these things, and also fluid air exchange, so that temporarily you can increase the intraocular pressure so that it tamponades and rebleed does not happen. And by the time the gases or the air is absorbed, the new blood cell which is treated also is stabilized, so thereby it does not bleed. So you can see the optic disc and macula totally clear, no hemorrhage, and this is how the fluid air exchange is done, and you can see the pan-retinal photocoagulation marks, and that's the conclusion of the surgery. The vision improved to 6/18. This is another patient with a traction retinal detachment. You can see a fibrous proliferation. This is a preoperative picture, and then this is a surgery where you again use a 25 gauge transconjunctival transsteral pars plana vitrectomy. So the entry point is very important. You go tangential and then enter. You can see the vitreous hemorrhage is there. You do a 3-port pars plana vitrectomy, and then you are now clearing the anteroposterior traction. And here I'm using a technique called proportional mode in the Constellation machine. I don't have any financial interest. So you see the fibrous tissue, which is totally adherent to the retina, but you can actually take in some fluid and then push the fluid between the membrane and the retina. That's what I'm doing now. So idea is to delineate between the retina and the membrane so that you have a cleavage space, and then again use the convex side of the fibrous tissue, use the cutter with the high cutting rate, low suction, and then you will be able to release the traction, and thereby you can clear the entire surface of the retina and release the traction. And if you are meticulous, the iatrogenic complications can be reduced. The usual iatrogenic complications are the recurrent hemorrhage, which you can avoid by diathermy, using repeated retinal brush to clear the surface of the retina, and also antivascular endothelin growth factor injection prior. And you can see membrane is being lifted up by pushing the fluid between the membrane and the retina, and then using the vitreous cutter alternatively. So the idea is you don't have to come out of the eye often to remove the instrument, put a forceps, scissors. The same thing can be done by bimanual, where you hold the forceps in one hand and also scissors, which I'll be showing in another video. And you have some, again, hemorrhage happening, you can clear. Then under the air, you can clear the surface of the retina and then do a pan-retinal photocoagulation. And time, the duration of surgery is also important, so that you saw during the conclusion there was a haze because of the cornea, then sometimes the lens, and then the air. So if you do the surgery meticulously and using the time and the cutter properly, you can go with the, and if this patient got, you can see the optic disc looks pale, but that is a diabetic eye has a problem. So generally I keep the intraocular pressure at 20, and then so that the optic is not affected, and you see the macula is clear, the same eye, and then the pan-retinal photocoagulation marks, and vision was 6/9. This is a third case, 49-year-old female with history of diabetes since 20 years. She was diagnosed to have a combined retinal detachment and cataract. She underwent phacoemulsification by my colleague, Dr. Kavita Rao, and 25-gauge vitrectomy by myself. And here you see a dense cataract with a vitreous hemorrhage. So Kavita Rao is doing the cataract. She's using the methylene blue to stain the anterior capsule, and then he's also using the viscous and then doing the capsular excess now, using the needle, and then she will continue the phaco and then introduce the intraocular lens, and then she actually also does corneal hydration, and then she goes out, and then I start the 3-port pars plana vitrectomy following that. You can see the phacoemulsification in progress, and you can see there's no glow because of the background vitreous hemorrhage. So this is again a challenge for the surgeon. You have to learn to use the whatever contrast you have for doing the surgery. The foldable intraocular lens being introduced. Sometimes she takes one suture, or they leave it with the corneal hydration. They leave it with one suture. Then I can proceed. You can see the corneal hydration being done, and then one suture where the IOL was put. Now I'm going with the 23 gauge, again going tangential, transconjunctival, transcleral, so that the wound construction is very important. The way you enter, there's a vitreous hemorrhage. Now I'm clearing the vitreous hemorrhage by doing the 3-port pars plana vitrectomy. So again, clearing the anterior posterior traction as well as the opacity. You can see a fibrous tissue after clearing the hemorrhage, and there's a looks like a hole, but that's not a hole. That's a pre-retinal hemorrhage in between the fibrous tissue. Similar procedure is done like the previous video, where now I'm diathermizing the fibrous tissue. Oh yeah, here this is actually a rigmodogenous hole which is there pre-existing, and I'm actually releasing traction between the retina and the optic disc region. And I've been dissecting the fibrous tissue from the surface of retina, and is releasing the adhesion between the fibrous tissue, and you can see some subretinal hemorrhage is being removed through the retinal hole. And then the subretinal space is clear. And all traction and vitreous gel is removed around the retinal break, which is already pre-existing, trimming the fibrous tissue and using the cutter with suction, trying to remove the pre-retinal hemorrhage. And diathermy against around the retinal break to delineate the break, diathermizing the fibrous tissue, which has produced the traction and combined retinal detachment. So all the pre-retinal hemorrhages were removed using the suction and the cutter. And if you have a proportional mode, you can do that. And also, retinal brush is being used to clear the surface of the retina. And the diathermy delineating both the retinal breaks, which is nasal to the optic disc. We're trying to do drainage of the subretinal fluid, and all the traction is relieved. And now the fibrous tissue is separated from the near the break from the retina, and then the fibrous tissue is totally trimmed. And make sure there's no oozing of blood by keeping the pressure high or using a retinal and pressing the against the blood vessel to avoid bleeding. Using a perfluorocarbon liquid in the posterior pole of the optic disc and the macula, and making sure that the PFCL is anterior to the retinal break. The idea is to flatten the retina. Now, under the PFCL, I'm using a vitreous forceps, grasping the membrane, and I'll use the light pipe to help to tease the membrane away from the retina, and also slowly judging the attachment and the traction. The idea is to avoid retinal break while removing the fibrous tissue. Now I'm doing endodrainage and simultaneous fluid air exchange using the retinal brush. Still the PFCL is there, keeping the optic disc and the posterior pole in situ. No subretinal fluid. And now the retina is getting attached. And you can see the retina is totally attached. The last drop is being drained. And if you see, I keep the retinal brush continuously over the break so that all the subretinal fluid is totally evacuated and dried up. And then I also drain the fluid in front of the optic disc, and then do the laser around the retinal break. Now the endolaser is done around the break, and now the pan-retinal photocoagulation is being done. This is a curved retinal laser probe. Idea is that through the one port itself, you can turn the probe all around. Almost 300 degrees you'll be able to do. Sometimes one part, maybe you need the changing the port. That means temporal to nasal, nasal to temporal. And now again, doing the final part of the drainage of pre-retinal fluid. And you can see the intraocular lens in position and the gas in the back of the eye. And this is again a twin light vitrectomy for a proliferative diabetic retinopathy. which allows excellent illumination, bimanual vitrectomy for a very tough traction metal detachment. So here you see the input is the infusion line is there, and this is a stiletto where you make the incision for the twin light endoilluminator to be inserted. That means you can see the two-pronged endoillumination cable is there, which is a chandelier illumination. It is like illuminating one hall using one light from one corner. Here we are using two light. That's why it's a twin light chandelier illumination. The advantage is you can use the two upper ports for doing a biman. So now I'm grasping the fibrous tissue with my left hand and using the dominant hand, the right hand, to do the dissection of the membrane, and also make sure that the membrane is totally removed from the surface of the retina without producing any traction or iatrogenic. So this way you can pull the fibrous tissue and check the traction and how much it's pulling, and then use the curved scissors. I feel like it's using a curved one of scissors, the vitreous curved scissors. So you need to develop a fine tactile sensation so that you know how do you grasp and how do you cut. And you should know, because you don't have the direct touch feel. And you can segment the membrane and then again delaminate it, and then you can remove it en masse. You may remove it in piece feel, as I'm doing now, and intermittently the amount of membrane which is dissected, we can also use the cutter to again cut the traction release membranes, and then also from the surface of retina. So better to avoid these sort of oozes which is happening. But if it happens, which sometimes is invariably it happens, and then you have to clear it. So here you can turn the convex scissors, see the posterior surface of the membrane, and see the adhesions and cut it and remove it. Here you are also segmenting and removing the piece. You can send it for histopathology, for any study. So here you separated the membrane, made into two parts, and then removing the. So this is another patient with a twin light, where again that patient all traction was released and then followed by endo laser and also FGE. Here again same, you see a tabletop detachment, catch the membrane and insinuate the scissors between the membrane and the retina and produce the cutting, and make sure that you're not going near the retina to cut the retina. So you have seen the proportional mode vitrectomy and doing the dissection, or bimanual technique where you grasp the membrane and then dissect the retina using the curved vitreous scissors, and finally removing the entire membrane en masse. Here you remove it in piecemeal or make it small bits and then remove it. Here I'm making a bigger small piece. So here you see the entire membrane has been caught, and you can see the membrane is removed en masse. So this surgeries may take 2 to 3 hours, and so that's why when you sometimes use a cutter, it is faster. But again, time is not the criteria. The criteria is the meticulous dissection, avoiding iatrogenic break. In the 80s, the iatrogenic break were about 18 to 19%, and now it's reduced to 1 to 2%. And The reason is that you are aware of the complications, and then you also know how to prevent it. And here you see the total fibrous tissue being removed from underlying detached retina, and then the entire piece is being removed. And if you want, you can send it for histopathology again for study. So, or you cut it and remove off, as you see with the cutter, and do a fluid air exchange, and then also combine with the pan-retinal photocoagulation. So, the favorable preoperative prognostic factor: short duration of macular detachment, limited extent of detachment, presence of preoperative pan-retinal photocoagulation, absence of vitreous hemorrhage. Favorable preoperative is a visual acuity of 5/200 or better, absence of rubeosis, which you saw in the beginning, absence of retinal detachment involving the macula. The unfavorable, which is what we have shown, macular detachment and combined retinal detachment, even though it is like a unconventional, is a bad prognosis, but I operate. And here we have come to a revolutionary technology to change the way a surgeon performs vitreoretinal surgery. It benefits the surgeon for a self-satisfaction and the patient for a lesser iatrogenic problem and an excellent outcome, and can be widely accepted platform in future. So this is a 3D vitreoretinal surgery. It's like seeing this vitreous surgery in the screen. You can see it in a big screen, like a 70 mm on the 3D, and then using a 3D glass, you can see. The traditional VR surgery posture is a challenge, leads to musculoskeletal pain, discomfort in the long run. So I suggest every vitreoretinal surgeon and ophthalmic surgeon to do exercise, strengthen the protagonistic and antagonistic muscle. That means the abdomen muscles and the back muscles have to be strong, neck muscles have to be strong. So do exercise, and also I suggest to do dance. The idea is to be having a strong gut and the strong back. Uses direct view of the endoillumination, sometimes with static filters. Prolonged exposure of patient's retina to microscope illumination or endoillumination, which is not there, the 3D. And 3D high definition cameras you see here. This is, I don't have any financial interest. This is with the Carl Zeiss with the Ingenuity from Alcon. A computer which processes the input and output signals, a high definition display unit, and 3D glasses to view the display. And this is the, again, with the unit, you can see the microscope with the 3D system, where you see the screen, the operation table, the operation surgeon's stool. The benefits: improved ergonomic posture at the microscope for several hours, which leads to musculoskeletal fatigue pain. So usually you have to operate like this, but you can now sit back and operate. With a surgical field displayed on a unit placed on a convenient position, the surgeon can maintain an ergonomic neutral position. This will reduce musculoskeletal fatigue or surgeon. But I think, as I told you, you can do exercise and use the microscope. But here, the benefit is better for the patient. Here you see me, I'm sitting erect, and I'm seeing the screen on the behind, and you can see my nurse who's there all the time standing. She has so much patience, Sister Joyce, and you see on my left, Dr. Aishwarya, retina fellow, who's wearing the 3D glass. You don't have to put your neck like that in the microscope and see. You directly see the screen, like big screen. So the eye muscles are also relaxed, because more you concentrate in near, the more there is a accommodation and then thereby strain. So it also has digitally enhanced visualization, dynamic contrast, can improve brightness even with low illumination, apply dynamic digital filters to enhance visualization, image quality often better than with a traditional microscope, digitally magnified, inverted image possible, and a digitally enhanced visualization, significant low, that's what I saw. I keep the low illumination about 20, and then it translates to lower phototoxicity for retina patient. You get beautiful video, and again, the video is to teach, and everybody in the operation theater can see this big screen. Filters applied can enhance visualization of stained tissue, which in turn requires dilute dyes. Digitally applied red-free filter, real-time responsiveness. The latency of digital technology added to the human reaction time is not very significant, but it is there. Ingenuity also has that latency, and also the Zeiss 3D RTO has. But I think it's a question of mastering the technology. So it is like driving a Mercedes or a BMW or a Fiat, but the driver has to master the clutch, the brake, and the accelerator. Then how you do it? So it's a question of similarly the same. And I always compare driving to the vitreous surgery. Same thing here. Both the legs are required to operate the foot switch, the laser, the microscope. You have a 3D glass to watch the screen, and then with my right leg you manage the vitrectomy machine. Vitreous surgical steps are often slow and delicate, hence the small latency added is not significant, but I think it can be. So you need to adapt yourself. This has a good adaptability. Switching to digital 3D VR surgery can be a challenge with the learning curve even for experienced surgeons. Fortunately, mentally I'm ready, so I did it. However, several surgeons have not reported any difficulty with the learning the technique. Advanced teaching tools, and that's the best part. I love teaching, and I want to teach surgery to my fellows like Dr. Aishwarya, where whatever I do, I think they have to know. So apart from looking into the entire procedure, they also learn to look at the mirror neurons in the brain. That means they have to know what I'm thinking, how I'm doing, and it's not only looking at the technology in that screen, but also the hands. And the display of surgical field is seen by the surgeon for the entire OT, and that's really amazing. So more than one person can train simultaneously. Tissues or areas can be pointed out on screen, and against instructing with left, right, up, down direction. Simultaneous heads up viewed by instructor and trainee improves the coordination during the surgery. Here you see, this is taken from my back, and on my left you see Aishwarya here, and you see in the front the screen. So you see my neck and back are erect, and that's because as a positive thinking surgeon, you're always erect. And here you see the vitrectomy machine and the 3-port in the screen, and you can see the nurse and the fellow doctor here. So this is a 3D RTO and constellation. As I said, no financial interest. You can see the optic disc and laser being done. This you can see the entry, and the whole thing. I know all this advanced technology costs a lot of money. So to prevent, as the president of All India Ophthalmic Society, and now as the chairman All India Ophthalmic Society for screening and awareness for diabetic retinopathy, I made a program called Screening through Teleophthalmology for Preventing Diabetic Blindness. In India, I called Jyot Se Jyot Jalao. And Dr. Babu coined diabetes invariously affects both eyes. The reason I showed this is that we have to prevent. Even though I'm an aggressive vitreoretinal surgeon, I love preventing blindness. So I have made a promise to the world and universe. So I seek the blessings of Lord and Swami Vivekananda that let us remove the diabetic blind from India, right? From prevention, screening, awareness, testing for sugar, HbA1c, the pamphlets, and then laser, injection, surgery, including 3D. And thanks to my grandfather, who was an ophthalmologist, my father, Dr. N. Sundaram, was the chief of the eye hospital, retired, and later he was in Mumbai with me and myself. We all studied in Government Eye Hospital, which is the oldest eye hospital in Asia and second in the world, with 150 years of service to the nation. So I follow my mentor, Swami Vivekananda, and my mentor in vitreoretinal surgery, Dr. Badrinath and Dr. Jovanovic. And whatever I am today, I owe to them, my Mata, Pita, Guru, Mitra, and Deva. And above all that, I have Swami Vivekananda, who says, they alone will live for others, and rest are equivalent to death. So, friends, I'm ready to answer questions, but I want to say that I want to give whatever I have. Give. The reason is here in teaching also. I want to tell all the secrets what I know in using the 3D fantasy vitreoretinal surgery for preventing blindness. And this is eye hospital where we are trained, the Government Ophthalmic Hospital, Egmore, and now it's the Regional Institute of Ophthalmology. And this is the oldest museum in ophthalmology, the Elliott School of Ophthalmology, where you have the models, you have everything available there. And thanks to my fellow, Dr. Aishwarya Iyer, who helped me in presentation, recording in the OT, and taking all instructions, following the SOP, and my executive to coordinate with Docplexus, Dr. Shitid, Narchika, and all of you here for and that's why I want to more. I'm grateful. I know we will do well. Thank you very much. And now I'm going to. How do I stop my sharing? Oh, yes.
Thank you so much, sir, for the educative presentation. The videos are very informative and I think it helps us also to understand better about the techniques and the tools. So moving on to the questions, we have some questions for you here. The first question is, in comparison with traditional microscope, how quickly can a surgeon be proficient in using 3D microscopes without any additional difficulties in both anterior and posterior surgery?
So always I follow this management philosophy and leadership quality where everything is in the mind first. Even Hitler or Napoleon Bonaparte or anybody, they actually win the war, including Ramayan, where the war is tomorrow, but they prepare their mental war field and they see how to do. Same thing with soccer. And the vitreous surgery is like soccer. Dr. Steve Charles is one of the authority on vitreous surgery. He has written Surgical Self-Education. He's compared the vitreoretinal surgery as a soccer, where you as a soccer player, like me and my team here is operating my fellows, my surgery, my nurse, the instruments, the equipment, everything. And here the opponent team is the patient's eye, the retina, the membrane. So you have your game plan like a soccer team. You go to the field, you pray and start the game, and then you don't know what the opponent is going to play. That means here, with your surgery, it will bleed or all that you anticipate. Similarly, how you trained yourself as a vitreoretinal surgeon or an ophthalmic surgeon, for a 3D surgery, one, you should know the theory, how 3D works. So you have played a 3D game. That's why they say, if you're a 25-year-old or 27-year-old surgeon, like Darshika and me, I'm also 25. So you can adapt yourself. But if you're an old surgeon and you're old used to the microscope, you're mentally stuck. It is like going from a gear to a gearless automatic in the car. You want the gear because you're used to it, but you don't understand the advantages of the gearless car or automatic car. So same thing here. Instead of looking into the microscope like that or like this, you have to look at the screen. That means there's a little tilt to your neck. So you have to make sure that you are comfortable, you're sitting comfortable. So I also designed a shoulder rest, hand rest, elbow rest, hand rest, and so that my lumbricals move. Second, mentally, I'm trained that I'm going to look at the screen and operate. And that's how I think it is like a vitreoretinal surgeon should develop 360-degree vision, but that's not practically possible. That means you have to be aware what's happening around you. Similarly, there's a learning curve is there, and that's why the Ingenuity by Alcon and that the other company, which are True Vision, which were accompanying, and they have come and demonstrated to me, as well as 3D RTO. They have a rule for every surgeon. First, they want you to use the same microscope or practice in the model eye for some 5 days or 5 times and then get in. And also, they tell you to do first one day, one surgery, and then go in. The reason is, I think you cannot experiment with patient. You have to practice in the model eye, where Arvind Hospital has made, and many eye hospitals have. Instead of bringing the animal eye or nuclear eye into the OT, you can practice that, where you put the thing and you make sure that your orientation is looking at the screen and operating. Because one is looking straight into the microscope, that means you're binocular, and now you're looking there and operating. So that means your mind and hand coordination is important. It's exactly like how females put the rangoli. And that's what somebody observed my grandmother and said, see her hand-eye coordination. Same thing here. So you have to develop that hand-eye coordination. So if you are not for example, if Dashika wants to try this, she's not used to even microscope. So when you want to see the microscope and do something, she'll be struggling. And then you have to manage your leg. It's exactly like learning a cycle. One day you cannot ride a cycle, even though it's a bicycle. So same thing. So I think you have to mentally train, then physically train. So for that, you should be sound with the theoretical knowledge, listen to the engineer who's coming, and also read about yourself. And mentally you're trained. I always tell my legs, my hands speak to the machine so that nobody needs to talk. So that means you have to develop that rapport between the machine and yourself. So for which you should not be a slave of the technology. The machines have to be your slave. The technology we have to be a slave. So I always tell them the 3G, the 4G, the 5G, the 3D, everything is developed by an engineer. Who's the engineer? He's a human being. No? So that's why even the diabetic retinopathy screening, I'm using AI, which is artificial intelligence. So I tell all my staff, the intelligence is lacking. That's why we are going to the artificial intelligence. What is intelligence? To analyze, scan. So same thing here. You should have intelligence, and you should have also work smartly. That means how you would adapt yourself so that you have to also pay so much for technology. And many times people want to give up, but I love and I do every procedure with 3D now. And it is not just because it's a fantasy and a new machine. It is like not going from a Fiat to a BMW or a Maybach and Mercedes. It is actually benefit for the patient because everybody will know what you're doing. That means you are cautious that you are going to demonstrate. Where the OT staff will know. If you, in the microscope, in case you don't have a sight tube, if you make a mistake, nobody sees. So that is why in management also they tell, leadership they tell, you should work as though somebody is watching you. And that's what is the microscope. But if you go out from 3D, and the difference between Ingenuity and this RTO is, RTO has a microscope also and 3D. But in Ingenuity, it's the what do you call, the computer head is fixed there. There is no binocular. So in case you want to shift, it's a problem. But here, my surgeons are having the luxury where they are not getting trained, but they're using the microscope and recording in 3D. I hope I've answered the. Oh no, yeah.
So that's I'm sure. So that's a very interesting take on the question that we asked you. Moving on to the second question. Is there any significant increase or decrease in adverse effects attributed to the 3D microscope?
I think it's like buying a car, and it is like I remember when I went from the TVS 50 to buy, and I think I was over enthusiastic, and I didn't know how to use the clutch. The clutch is in the hand, and then the TVS 50 is simple. So I actually cut my finger because the first gear, the second gear, you didn't know how to do, and the bike moved. Same thing here. If you don't know the technology and you're going to operate a patient, then it will have adverse effects. So best is to be confident, not overconfident, and then start the procedure so there's no adverse effect. And second, in the RTO, if you are stuck, you can go back to the microscope if you are used to it. So, and fortunately, here is more benefits. Again and again, I want to tell this no financial interest because some companies will take my quote and say, oh, they are doing it. No. Now I am also want to use that Leica, where my friend Barbara Parolini in Italy is using it. I want that company to come and give me the demonstration because I love new toys. Unlike my two old mentors, both are stuck. They said, my staff don't want to learn new, so I don't want to learn new. So I am not like that. I learn the new and I allow every doctor, every staff to use the new technology because we have to learn the 5G technology for everything. So now I'm glad I'm a president of Teleophthalmic Society of India, and with Dr. Hunter, I'm now going to learn how to transmit 3D vitreous surgery like this even during the webinar, so that you all can wear a 3D glass and watch my 3D surgery. So that you'll be fascinated, so that regular surgery can take up vitreoretinal surgery.
Definitely, sir. I think,
so I think
all the best for that, so that we can also. Sorry, so please go ahead.
Yeah. No, it is like a driver's fault. If the driver is not, that's why when I get a driver from a Fiat to or whatever Honda City and every car and go to a Mercedes, one, because of the expensive. Second, if you have an accident, you have to make more. Here, the accident is patient, which you cannot tolerate. So no question of tolerance. So I think it's a driver's mistake. Here, it will be a surgeon's mistake if you have adverse effect. So you master the machine. Make sure you have all your doubts cleared, then touch the technology. And here your advantages, you can use less light, so the machine also will not go up. Patient's retina is protected, and I think a lot of benefits. And the side effect is only you have to learn some new technology. See, I feel I want to quote Mahatma Gandhi: "Change is the only constant thing in my life." And also Gandhiji says, if you want to see a change, you see the change what you want to. So I made my hospital also does not look like a hospital. My rooms are not like hospital or clinic. And same thing for vitreous surgery. Many times patients don't know they are operated because we are using a 25 gauge 0.4 millimeter entry. And if you're so careful, the next day patient does not know, even I don't know which I operated. Sometimes this doctor, you only operated, they tell me. And then when they have a pain, I tell them, no, and then you should know, otherwise you don't know whether operated or not. So it's not for self-boasting. I think that's what I've learned from Dr. Badrinath and Dr. Jovanovic. And that's why we have few of us are in the Retinal Hall of Fame, because tissue care is the most important. That means you care for every cell in the retina for the patient to see. That means we love every patient.
So those are, I think those are one of your greatest leadership skills as well. So moving on to the other question, what are the post-surgery monitoring parameters for vitrectomy?
No, I think it's like for any surgery. So one is intraocular pressure, inflammation, infection, and then if you are mainly intraocular pressure, so if you are using intraocular gas or air or even silicone oil, so the intraocular pressure has to be measured, and regular post-operative, and sometimes we have to position the patient to make sure patient is doing the follow-up, and also explain to the patient, look for any sign, untoward sign, and second is make sure that the patient is aware, and also make a system where as a surgeon you may not be directly available because the patients do not know the thing, but we are make sure that the assistant, the nurse, everybody is available on a call, so that the patient has a difficulty, they should be able to call, and you should be able to call the patient to the hospital for checking.
Okay. Sure, sir. So the last question for you here is, the resolution of traditional microscope with eyepieces is usually higher than the 3D system. Do you find any difference with the 3D image compared to traditional microscope? So any points to be kept in mind during the surgery?
I think I don't know. Maybe you're talking about the quality of the image, but one thing I find is it's like, for example, this is the cover of the page. Sorry, this is one membrane of the like a membrane, and the underlying retina is here. So here you can see the difference between this two layer in this 3D technology better than the 3D regular microscope. Even though you have a zoom, if you zoom, for example, like this, you zoom this part, like D, you will be suddenly seeing only the D, right? But in this 3D, you can see the full and also the zoom of N. So I think, I don't know whether, am I right, Dr. Aishwarya? Yes, no, when you magnify in a...
You can magnify in this up to 100x.
No, you magnify, I think the question is different. No, they are saying microscope is better than 3D.
They are asking whether the quality changes.
No. I feel it's better with, maybe I love 3D. And I think there's a quality difference is there in the quality of image. But I think in the recording and for the patient surgeon, I think this depth perception is well appreciated.
Hello. Natarajan, I think, is facing some issue with his network. So since doctor's video, I think he's facing some network issue, but we have the question answers as well. So I would just like to thank him for his time and taking out time from his busy schedule and talking to us live on such a new and innovative topic. So I am hoping that all of you watching us live really enjoyed it, and we will be open for any more questions if you have. You can comment the question below. Thank you so much.